Thanks again, John, for that introduction. And the title of the talk today is The Patients We're Not Seeing, Ideas for Expanding Our Reach. These are my disclosures. I just want to bring up that one of the this disclosure is relevant to the presentation. So I'll talk a little bit about what Maryland BHIP is and the ECHO program that they have, but it's funding, and I don't know why it's going forward. Here are the objectives. So describing gaps in access to mental health care for children and adolescents and key contributors to the gaps. Why is it? Sorry, I'm not sure why it's on this timing. Okay, let's see if that works. And then I wanted to talk a little bit about some ideas for increasing access to care. So I wanted to, we often start our grand rounds with a case presentation of patients that we do see. But today I actually wanted to talk a little bit more about the patients that we don't see. And part of the reason for this is that there's been a long-standing gap between need for mental health services and access to care for youth. The standard figure that we often present in the child psychiatry access programs, which I'll talk a little bit later, is that 80% of youth with mental health needs go without services. And this has been exacerbated to a critical point in recent years. The headline on the right describes a recent story in the New York Times about the influx of mental health patients in general pediatric practices, most of whom are not in care. And so this is called the need to access gap, meaning there's a big gap between mental health needs and those who have access to care. The crisis led to an advisory by the Surgeon General in 2021 about youth mental health. And I know this has been discussed by previous grand rounds by my colleagues, but I wanted to highlight it again because advisories are put out to call attention to what is described as an urgent public health issue that demands immediate awareness and action. And the goal, as put out by the Surgeon General at the end of this report, was to move towards ensuring that every child has access to high quality, affordable, and culturally competent mental health care. And it was emphasized in that report that our obligation to act is not just medical, but moral. And again, this was also discussed in recent grand rounds by my colleagues, so I won't belabor the points too much, but I did want to highlight, again, the significant impact of the pandemic on youth mental health. Many would say there were significant challenges prior to the pandemic, and hence the description of a tsunami on top of a tidal wave. But some figures here. A recent global meta-analysis reported a doubling of pre-pandemic levels of depression and anxiety amongst youth. The Children's Hospital Association reported a 42% increase in ED visits for suicidal thoughts and behaviors in 2021 as compared to 2019. And a study that just came out in the Journal of Pediatrics in February described relatively low rates of engagement in outpatient care after ED visits for suicidal thoughts and behaviors. And this has not just been amongst youth, again, this has been really in the media a little bit more. The overall Department of Psychiatry at Mass General, there was an article in the Washington Post where they described a wait list of over 800 patients and that there were pleas to stop referring psychiatry patients for non-urgent care. So what are some of the problems with lack of timely access to care? Some of these are self-explanatory, but I think it's worth emphasizing given the length of the wait list that we hear about. And I speak about this from the standpoint of frequently being in touch with my pediatric colleagues, having trained in pediatrics. So longer waits for care are associated with higher risk of decompensation, increased likelihood of returning to the ED for those who presented to the ED. And then we know there's a body of knowledge around outcomes for things like duration of untreated psychosis or duration of untreated depressive symptoms. And then finally, wait lists can prolong the distress experienced by patients and families. And then a study actually done at Bayview CPP showed that longer wait lists were associated with higher rates of no-shows at appointments. So what are some of the barriers that children and families face in accessing mental health services? These barriers can happen on multiple different levels, and I'll spend some time on each of these later, but wanted to give an overview here. So for some, it may be that symptoms are not recognized as a problem, or they're recognized as a problem, but there's difficulties navigating or figuring out what to do about it. There can be barriers related to perceptions about treatment. So are the services offered or being offered seen as potentially helpful, or are there concerns about how patients might be treated in care, whether they might be supported versus dismissed or blamed? And then for some families, we hear about concerns about consequences, for example, involvement of child protective or social services, or consequences for their child of being labeled as having a mental health problem. There are also missed opportunities for screening. And then there's barriers related to the services themselves. So things like cost, location, the design of our services. And then finally, there's competing demands to engaging in services such as social needs. So these barriers are disproportionately experienced by minoritized youth and families who are less likely to receive any care at all, and to receive what's described as minimally adequate care. And why is this? So there's a number of reasons, and one relates to what I was just talking about, so the prevalence of competing demands. Unmet social needs are both related to or a precipitant of mental health services, but also a barrier to care, as some of these may take precedent over engagement in care. And I alluded before, the degree to which treatment is perceived as helpful. Are we focusing on the right things? And one of my colleagues talked a little bit, I'm going to talk a little bit about this at the end of the presentation. And then some have to do with the composition of the mental health workforce. So one example of barriers to care is insurance and cost of services. So in one study based in Ohio, researchers posing as parents telephoned randomly selected offices seeking care for a hypothetical 14-year-old patient under different scenarios. And in adjusted models, they found that patients with Medicaid had longer wait times than patients with private insurance, although I think many of us can come up with examples of the reverse. That happens here. And then other studies have found differences in markers of quality or adequacy of treatment by insurance. And then there's lack of insurance. So here at Hopkins, we're lucky to have the TAP program, which stands for the Access Partnership, which helps provide access to subspecialty care for those who do not qualify for insurance. But a relatively low proportion of TAP patients are actually seen by psychiatry, and a number of programs may not accept TAP, which essentially eliminates access. So this quote on the right here, again, was based actually on a focus group study that a team, some of whom are probably here, did related to youth suicide. So they talked about here the challenges related to access to services, and that one, potential way to decrease suicide has to do with making therapy more accessible. And then I also wanted to call attention to the role that language plays in mental health care access. And I know this is a really complex topic and that there's subtleties and challenges with use of interpretation in mental health care that often come up in discussions that I have with colleagues. But I also wanted to call attention to this report that was released in 2022, describing cases where, despite a legal requirement to provide interpretation and translation, families were denied services due to the language spoken, or separate wait lists were created, some of which were unintended based on language. So often the first step in identifying mental health need is screening in primary care settings. And as several folks here are familiar, this can be a multi-step process, which ends up being more complicated than one might think, and has the potential to exacerbate disparities. So in a scoping review of pediatric integrated care that I was a part of, that we published a few years ago, challenges with screening were mentioned so frequently that we dedicated an entire section to the topic. And even though universal screening is the goal, we found that it was pretty, even in cases where there was one example of a very highly resourced, they had somebody who was dedicated to assisting with screening and making it happen, and they achieved rates of about between 60 and 70%. So there's lots of potential challenges with screening. In my own work with babies, pediatric primary care clinic, low literacy can be a concern, complicating screening processes. There's differences to how people respond to or understand screening, and there's some evidence that lower cut points for concern might be appropriate for some populations. And then finally, I hear both in obstetrics and pediatrics about the concerns that clinicians have with screening altogether, given that there's such limited resources for referral. And again, I think both my colleagues Nadia Zaim and Liz Reynolds may have both shown this workforce map before. But I wanted to show it again just to illustrate the fact that this is like a regularly updated workforce map by the American Academy of Child and Adolescent Psychiatry, showing that a huge proportion everywhere with red has no child or adolescent psychiatrists at all. And then most of the remainder of the country has what is described as a severe shortage of child and adolescent psychiatrists. And then there are the issues, then there's the issue of, how our workforce is doing, particularly in the current setting, and maintaining our workforce. And then there are also barriers to the way in which services are organized. So a colleague at Yale, Miraj Desai, is a psychologist who looks a lot at mental health clinic organization and described what he noted as a frequent implicit preference expressed by the system or the providers for patients who help the system operate efficiently, which may intentionally or unintentionally exclude those who don't fit into that box. We hear also from pediatricians about challenges that many families experience with clinic policies or hours, and noting that these policies might exclude some of those who have the greatest need. And this is obviously complicated because a no-show also means that it was a time that could have been used for someone else to expand access. And then also with our hours, we obviously have to take into account what's reasonable and sustainable for our clinicians. But just to say that this might contribute to barriers. And then finally, an obvious barrier barrier to expanding access relates to our ability to do so because of reimbursement. So really, there's no easy answers. And this kid, I would say, agrees with that. Where do we go from here? I wanted to share a few ideas that I have related to expanding to access to care. And there's obviously many other ideas as well. And I'll talk about each of these 5 ideas separately. So one is using a public health approach, using a system lens to examine and refine our existing programs, embracing innovation, looking at success stories, and partnering with families and communities. So first, thinking about a public health approach to mental health services, I think we need to contribute to efforts to actively address prevention in addition to treatment. And as a reminder here, primary prevention relates to avoiding disease development altogether. Secondary prevention targets those who are at higher risk for disease, and tertiary prevention relates to reducing complications after a disease develops. This is a busy slide, I know, but I wanted to just provide an example of how some have thought about constructing a public health approach to mental health services, or a population health approach to mental health services. And this was a paper that was focused on the impact of COVID-19 on population mental health. They describe a menu of interventions from primary to tertiary interventions, with primary interventions targeting social determinants of health and social risk factors for mental health problems, with services potentially delivered through task sharing or digitally, or with mutual supports within the community and of low intensity, to secondary interventions, which might target those who are at medium risk or higher risk. And those include brief evidence-based interventions, potentially of higher intensity, and then followed by tertiary interventions for those who have already experienced mental health outcomes. And that's what we're traditionally focused on seeing. So going back to primary prevention, these would be interventions that would address factors influencing the development of mental health problems, and often those could be universally delivered. One example of this is Healthy Steps for Young Children, which is designed to be delivered within pediatric primary care. It's a tiered program, meaning that some components are universal and others are delivered to those with risk factors or symptoms. And it involves the use of what they call a Healthy Steps specialist, who is often a social worker or mental health provider who provides support for early childhood development, including parenting education and support. And we know that parenting in early childhood has a significant influence on the development of on the development of mental health problems later. Healthy Steps has been found not only to impact parenting outcomes, but also somatic health and healthcare outcomes, for example, vaccination rates. Sites delivering Healthy Steps now can actually receive enhanced reimbursement by Maryland Medicaid. So I think interventions like these are something we could consider, and perhaps some of the reimbursement barriers have been lowered. Another example of primary prevention includes universal social and emotional learning programs in schools. And then place-based interventions, which relate to the changing characteristics of the environment. Secondary prevention include early identification of symptoms and prevention of progression, and that might include more focused attention to screening or psychoeducation and delivery of programs targeting youth at risk. One example of this is called the Family Checkup, which is a brief family-based intervention aimed at promoting positive parenting amongst those with risk factors for future behavioral problems. And then another with the team that I've been working with is called the Mothers and Babies course. And this is designed to be delivered to those at elevated risk of perinatal depression, either due to score on screening measures or psychosocial characteristics. So we've been partnering with Maryland Judy Centers, which are early learning centers across the state, to deliver mothers and babies in this setting. So speaking of public health approach, the CDC, a public health agency, I wanted to just call attention to the fact that they actually recently released a report on increasing access to children's mental health care in 2022. And they made several recommendations, including improving strategies to connect families to mental health services. And within this, they talked about integration and school-based services, which I highlighted before and we'll talk a little bit about later on. Then understanding gaps in the workforce and increasing capacity of other providers, such as primary care providers, to address mental health. Investigating how funding policies affect mental health, or a mental health service organization. So how does reimbursement of things like mental health and integration, for example, influence that? And then they describe understanding social determinants of health that make it harder for some families to access care. So that's a whirlwind overview of a public health approach to increasing access to care. Another idea is taking a systems lens. And I think this was thought about a lot during the pandemic, when health systems had to think about access to inpatient beds, ER management ED management, ICU management. And this is an example at Hopkins of how system science, often led by engineers, looked at what they called optimal strategies to reduce the burden of COVID-19 on hospitals. And I would argue that particularly thinking about Liz Reynolds' grand rounds a few weeks ago related to boarding of mental health patients in the pediatric emergency department, that we have similar challenges for child mental health. We could be thinking this way about factors contributing to wait times in the outpatient setting, in addition to the sort of bottlenecks that Liz talked about at her grand rounds. One example of using a systems lens is called participatory system dynamics. And this is a process through which a group comes together to build a collective model of the issue. And the process is associated with them. So for example, if the issue was long wait times for initial mental health appointments or service use disparities, a group is convened, and that includes those with the most knowledge of the challenges, including frontline staff and patients who participate, think about how various factors influence the issue. It could be things like appointment duration, provider well-being, et cetera. And then to look for sources of data, for example, in the electronic medical record that could be used to calibrate a model of the issue, which could then be used to simulate the effects of different interventions on the outcome of interest. And for those who are kind of intrigued by this, the VA has a really neat program that they've built. And I put the website down there. So they've kind of inputted a lot of their variables into it. You can sort of take a look. I'll show us a slide in the next, or I'll show the next slide has that. But I think approaches like this could be helpful to us in sorting out how to optimize processes that we have in order to address challenges to access. So this is an example of one of the things that they do in terms of having inputs and where you can sort of test, if we did this, what might the impact be based on the data that we have. So the next idea I have is to embrace innovation. And I wanted to start with a quote that I think is telling, which was from 2011, but I think the same thing essentially applies now, which is that we need to have we may need a major shift in intervention research and in clinical practice, given the current crisis. I wanted to review an interesting article that came out last year by Enola Proctor, who's a prominent implementation scientist, and colleagues. And this discussed the role of innovation and speed in thinking about bridging the gap between research and practice and bringing innovations into practice. She describes a tendency for most systems to be reactive versus anticipatory, which can hamper the implementation of innovations. Factors that might compel the speedy rollout of interventions include rapid health and social crises. So thinking about COVID-19 and the development of RNA vaccines, which was incredibly rapid, relatively speaking. You could also argue that the current pediatric mental health crisis demands the rollout of interventions. And this is particularly true for those experiencing inequities. So for example, I wanted to bring folks back to Liz Reynolds' round. So the example of the crisis of boarding in pediatric EDs, compelling the Bridge program. So Liz gave a great presentation about this and about the development of a program to decrease bottlenecks in care, including providing bridging between levels of care, among other things. I wanted also to share an example of a program that is anticipatory with innovation. So the Levy Healthcare Incubator at Dartmouth is a program that was established to bring about rapid, what they say is to bring about rapid, sustainable, scalable, and transformational healthcare redesign. And they have a program where multidisciplinary teams can apply for and receive funding and support for a year to design, implement, and evaluate innovations, receiving mentorship from subject matter experts, administrative support, et cetera, to carry out a project. And one example of a project that developed from this is a modular program that can be developed or delivered to youth boarding in the emergency room again. And I'm not going to go through the whole table, but you can see there's a number of structures that they've put in place to support this program. So what are some of the innovations that have been recommended to expand the reach of mental health services? The list here was developed for an article related to expanding the reach of psychosocial interventions, and I'll give a few examples of those that are in kind of light green up at the top. So one type of innovation that it's been traditionally used more in low and middle income countries, but is increasingly being used here in the US is the use of lay health workers, such as community health workers within the mental health service system. And the article that I'm citing here just presents a nice conceptual model of the roles that lay health workers can play. And they could be addressing demand determinants, for example, barriers to care, where they might play more of a role of a navigator, versus supply determinants, where they might be supplementing or delivering services, mental health services directly. So some local examples of task shifting or task sharing that I wanted to, again, call out the excellent presentation that Dr. Zaim gave about a month ago related to the work that she's doing with primary care providers and with pediatricians in the hospital. Then Joyce Harrison and Amy Betancourt have been involved in Maryland BHIP, which is Maryland Behavioral, excuse me, which provides provider-to-provider consultations and longitudinal trainings, and then has more recently expanded to providing support in emergency room. Then there's school staff delivery of interventions. And so that's another sort of example of task shifting. And Amy Betancourt, again, has been supporting delivery of the Chicago Parent Program at Judy Centers. And then we have also been transitioning our delivery of the program to school staff. So some interventions are designed for this. And then for examples of community health worker directly delivered interventions, Centro Sol at Hopkins has been delivering an intervention in partnership with the Esperanza Center for mild to moderate symptoms of depression. And then I'll talk a little bit about a safety planning intervention that's coming. And then I know that there's folks here who have also used lay health educators in a variety of capacities, including the Congregational Depression Awareness Program. So looking at what was the next kind of light green on that list was what was called disruptive interventions. And this was described as altering the characteristics of interventions to make them more feasible. And one example of this that has received increasing attention in youth mental health are what are called single session interventions. And they're designed to intentionally involve only one encounter or visit and have been developed for a number of conditions in both therapist and self-administered formats. They have been found to have a small to medium effect size, and there could be a role for offering things like these, for example, to people on wait lists. And for some, interventions such as these might be sufficient and ultimately could decrease the length of our wait list. I wanted to call attention to the website here for those who are interested in taking more of a look at this, as there's several open access interventions that are available on this site. Next, I wanted to look at a few success stories related to some of the challenges that I brought up at the beginning of this talk and think about how we might learn from them and apply them as well. A few examples I'll give relate to screening, behavioral health integration, rapid evaluation centers, so similar to the Bridge program, and family navigation. This is an example of concerted efforts to increase mental health screening within UCSF's health system, and they describe targeted efforts to identify and address disparities in mental health screening over a 2-year period. And you can see there was a significant increase in screening rates and a reduction in disparities, which were most notable by language. And that had to do with really convening a task force that was specifically focused on this, as well as quality improvement, as it being a quality improvement project tied to funds. And they had pretty marked increase in screening rates over this time period. Just as an example of this, a project that I've been involved with that I alluded to before relates to incorporating a community health worker to not only to support screening of families who, or of children who oftentimes face barriers to screening related to language, but also to provide navigation and support the process of safety planning for those who are identified to be at increased risk for suicidal thoughts and behaviors. So this is another example of a clinic or a health system's efforts to address significant wait lists for mental health services. And this was a quality improvement project at an FQHC in Washington State, where they described how over 3 cycles of improvements, the wait list for psychiatric services went from 350 to 1. And they described different efforts and the influences of those efforts, including co-locating a psychiatric provider, using e-consults, and then implementation of the collaborative care model, plus the use of a mental health navigator in addition to waitlist review. And this might be particularly relevant given that there's upcoming legislation in Maryland to expand access to collaborative care here. So this is an example of integrated behavioral health services in pediatrics and wait times for mental health services. And this is from Nationwide Children's Hospital, whose program is partially funded by a Medicaid ACO. And looking at pediatric primary care patients between 2016 and 2018, they noted that 93% of those who presented with mental health complaints were seen the same day. And for those not seen the same day, the integrated provider was able to see the patient within a mean of 11.4 days as compared to 48 days for traditional behavioral health services. And this is a little bit more on the nationwide model, and it's a visual depiction of their program, which includes support to the primary care team without direct contact in one tier, joint appointments, including early childhood prevention visits and warm handoffs at the next level, co-located visits for those needing follow-up, and referral to traditional behavioral health services for those who didn't respond or to lower levels or present with high acuity. And this is a nice example, I think, of an integrated public health approach to pediatric mental health. Another example of a model that Liz Reynolds referred to in the development of the Bridge Clinic here is the Duke Children's Evaluation Center. So this was established to address high rates of ED utilization for mental health complaints and lack of timely evaluations and outpatient care. The evaluation center serves as both a triage center and an outpatient mental health clinic where patients can have up to 5 visits, and they take referrals from the ER, primary and specialty care, and the community. They wrote a paper about their first year of operation, during which they saw 641 different patients, noting relatively short wait times and a decline in ED visits among those who presented to the evaluation center. Another example of a program focused on increase in access to care, and in this case, access meaning at least diagnostic ascertainment of autism spectrum disorders amongst those who were referred, is the use of family navigation. I referred to this earlier, but this is an example of a use of a community health worker to address barriers to care, and was found to increase likelihood of diagnostic ascertainment, especially for families who identified as Hispanic or Latino. And then a brief whirlwind overview of the last idea related to expanding the reach of our services, partnering with families and communities. Andrea Young gave a great grand rounds related to this topic a year ago and challenged us to think about the treatments that we're delivering and the degree to which they address the perceived needs of families. And she had done a study that showed, a pretty low report of perceived match between the child's needs and the treatment perceived. And that being one example of disengagement or leading to disengagement for care. She talked about a study that used person-centered cultural assessment, which in this case was the use of the cultural formulation interview at the time of intake assessment to get a better understanding of families' perceptions, needs, and goals at the outset, and how this may ultimately relate to improvements in engagement, particularly for minoritized families. And then beyond thinking about how our services are organized in the clinical setting and about, we should think about where we are partnering. So my colleague Hal Kronsberg gave a great talk last year about the school-based program at Bayview and the importance of that setting as a point of access for youth. And in work that I've done with colleagues around suicide prevention, school-related activities were repeatedly described as critical to youth suicide prevention. And then others have looked at developing and partnering with community organizations serving youth and families to develop and further deliver trainings to increase capacity of those who interface with youth daily. And this is, I think, something we could also consider playing a role in, again, thinking about primary and secondary components of a public health approach. So in sum, I would argue that there's not only a crisis in child and adolescent mental health, but there's also a crisis in access to care, particularly for those who are at the greatest psychosocial risk. We know that delays in care can have significant adverse effects. And I think addressing this crisis will require concerted efforts, and some ideas to address them, as I had mentioned, include focusing more on a public health approach, paying attention to our systems and how they can be adjusted, a willingness to embrace innovation and learn from others' successes, and partnerships with families and communities. I think that's it.
Well, thank you, Rheanna. Thanks for a wonderful talk and a real overview of the challenges we face in terms of pediatric mental health. I wanted to at least open things up for some questions. There was a comment from Geetha Jarayam in the chat. Geetha, would you like to formulate that into a question for Rheanna, or
I'm
join
happy
in?
to hear about the program too.
Yeah.
When my question is really, honestly, why I've said the United States is really behind many low and middle income countries in instituting a method of quick intervention and then community support following any other treatment that the patient gets, inpatient or outpatient. And we're way behind because payment systems are tied into how you practice, and payments will not happen except for specific codes, specific ways of intervening, and insurance companies are way behind. How do we suggest we make a change to incorporate this?
Yeah, I mean, I would say to some degree, I think the crisis that that everybody has acknowledged, particularly in youth mental health, although I know I'm sure that folks would probably argue there's an equal crisis. I think, it sounds like there is some policy movement towards changing the way things are done and some recognition that what we're doing right now isn't necessarily working. And I think that that's been advocated. I guess the question is the degree to which it's acted on.
Yeah, so I mean, I'd love to talk with you later about a way to maybe even do a little model in the community for youth, okay? Thank you.
That sounds great.
That's great. While we're waiting for other questions, I'll ask a related question, Rheanna. I mean, one of the things that you mentioned, and I agree with, is that really when we're presented with children and adolescents and families in crisis, as we often are, we do have an obligation to act, and it is a moral obligation, and yet, societal reimbursement and support for the kind of response that these children and family needs is pretty much lacking. How should we and other academic medical centers respond to this moral obligation, given the current challenges with reimbursement?
Well, I guess one example, and this person she's sort of like a tour de force. So the person who now runs the 0 to 3, I'm blanking on her name, but she used to run Montefiore's pediatric integrated care program. And I think some of it was really just a compelling presentation. So they knew that, for example, there was not going to be immediate return on investment for delivering pediatric integrated care. But she was able to convince leadership, like, we've got to take a life course perspective. This has to be part of what we're doing. So I think making arguments like that, and again, we've talked about services at Bayview that I think sometimes the way that we're looking at how things are reimbursed, we're not looking system wide. So, for example, the impact of closing a program might have broader influences than it seems.
Yeah, so this idea of looking at services in isolation, or looking at departments of psychiatry, for example, as self-maximizing units instead of in the larger context of what it brings to the medical center at large, I think is an important perspective. Dr. DiPaolo had a comment here and a question in the chat. Ray, do you want to jump in here?
I'd be delighted, and thanks, Rheanna. This is a really good presentation, and repetition, after all, is the mother of pedagogy, so don't worry about the repetitions. But I do want to point out that actually some of the things you brought up, particularly the systems approach and the innovations approaches, have actually been tried in Maryland and have failed. and they failed, as you know. Well, okay, good. So one is just to reemphasize the point I put in the chat right away, and that is that in most clinics, mental health clinics at least that I've been involved with, delayed the gap between the time that you call and the time you get the appointment always increases no-show times if it's beyond the period where the crisis might have, in a sense, settled down, not necessarily for good
Right.
or for good with a good benefit, but the bad thing may have already happened or whatever else. And I've seen that both in our CPP program, which we looked at, and one of the things that used to be done out at Bayview way back when, before they really had a fully fledged CPP program, was they had a crisis clinic where, and actually I think it's been tried in our CPP program, where you have a walk-in day morning once a week or once a month. I'd be very interested in that because it's simple and it doesn't require everybody, all the system to agree to that. Does that work?
So I know that we used to have it. I think it was still in I think probably my colleagues at Bayview, it was around for like maybe a couple of years after I started at Bayview, but it hasn't been involved. It hasn't been for some time. I think there are other programs. I mean, I think we know, for example, it seems like at the higher level, so what Liz Reynolds presented before, it's sort of, where is the crisis access point? Is it the ED? Or is it, I think that's how the Duke program was also developed, was that it could be for those, not just those in the ED, but also crises presenting, at different points along the time. But I don't know, I think the other part, and I think someone else brought up this issue, this very real issue of like, how are we managing the work? Again, this is like complicated because right now we don't have necessarily the workforce to kind of add additional things. But
well, I do think that, by the way, that is interesting, and I can tell you the problem with the walk-in clinic is it gets oversubscribed, right? And then you can't see everybody, and so I know that's a bit of an issue, but I do think that at least helps you get to some of the people, and there are ways to kind of manage that. We can't see everyone. The only other point I would make is simply that the other issue, my daughter works in the Kaiser system down in the southeastern U.S. and is right now in charge, I think, crazy that she took this role, in charge of access. And what she finds in mental health, she's a dermatologist by training, is that the therapists, communities, and they're not just one profession, but many, tend to have a pattern of seeing people like once a week in perpetuity almost, or so it seems to the administrators. Is that an issue? And do we need to, you mentioned the one visit intervention, but is that a big issue as you see it?
I mean, I think so I think in terms of paying attention to systems, if we're really focused on paying attention to people who aren't in treatment, and I think people will say, there's like the recovery model, like there are some people who I think need long-term treatment.
Sure.
But I do think we could, pay more attention to, does this person, and I know people do this anyway, but I think one question was, could we be systematic about it? But I think that involves, that the way, my sense is that the way we function right now is we're really focused on as we should be, on the patients that we're taking care of, but not on who are we not seeing because of how we're organized.
Thanks. That's terrific. Thanks.
Right. One of your points there, I think that's relevant for Ray's question, is just the value of integration, because one of the things we know is every time there's a transfer from one site to another site, there's always a decrement, which really speaks to the value of integration. There's a question from Dr. McGuire, who is asking what might practical next steps be that we can take as both researchers and clinicians.
I mean, I think some of it could be, are there opportunities to, knowing that who we're seeing in our office is a fraction of the need. Like, where are the opportunities to be partnering and sharing our expertise with others? So sort of, similar to what Nadia does, but thinking more broadly about how we might be able to partner. And then, so as both clinicians and as researchers.
Okay. Thanks, Rheanna. Dr. Goes has a question in the chat. Thanks, Rheanna. As always, a child psych talk that is 100% relevant to adult care. Maryland has the unique single payer system. Does this help to focus where advocacy needs to be targeted? Any thoughts about that?
I mean, I feel like I don't fully, I know in terms of the single payer system and the hospital-based clinic, I know people feel, to some degree we're hampered expanding services, even though it's a time when we need to be expanding services, in part related to this. I guess it's not necessarily the single payer. And so I guess, Fernando, are you talking about single payer as related to like mental health carve-out?
Yeah, I actually also don't fully know what the single payer is. I know it's I think we need clarification. I know it's very influential for us, but I thought the whole reason of the single payer was to try and balance out a little bit what state of Maryland, in terms of if they think that there's that certain things such as psych care is important for the state, there's a way of sort of balancing out to increase the revenue that goes into mental health care compared to just a capitalistic system. Because ultimately, I mean, it's not everything, of course, and it's not something that we like to think about, but the elephant in the room is money, right? It's just we're losing people because we're not able to give providers enough of a salary support to help take care of these challenging problems in relative to what they get paid in other aspects of society and other aspects of treatment as well. And I thought, I mean, again, I don't quite know enough about the details, but I thought the single payer system was in a sense to get a better handle on these sorts of things. So I probably just raised some things that are not true, but that was the intent of the question. Yeah.
Yeah, I mean, I know, and I think that, I'm just reminded when you're saying that, I think that some of it is like related to our relative value as clinicians as compared to other things. So even, when the dean of the medical school came and said, like, child psychiatry is really important, and the system does not necessarily think that way. Like, the system is not reimbursing.
Yeah.
So I think, but again, I think that the current crisis is an opportunity to advocate to some degree and say, like, look, it is really important. We're not doing things that are traditionally reimbursed, but if we want to actually address this crisis, we have to deal with it. I think that Maryland they have a bill in the legislature this year that's like, I think it might just be to like study, but it's something related to the mental health workforce. So at least there's a recognition that we need to be thinking about. And the obvious, you probably talked to a few people, and you wouldn't necessarily need a commission to say, like, people need to be paid more, but
yeah, on the one hand you do. I think it has to be that clear because we're losing a lot of people because of that. Yeah.
The Maryland strategy is essentially a cost containment strategy, which in the long run ends up being an access prevention strategy. Ray, you were trying to get in here?
Yeah, just to make the point, your point is exactly right about the global budget, that is the annual budget that doesn't change very much, does disincentivize the hospital for putting out resources. And that's an unfortunate thing because before that, it was the Medicaid expansion that got us out of an even worse rule, which was we couldn't see people in our CPP unless they had insurance, which was crazy. And just the people that needed to be seen couldn't be seen because they had this deal that they wanted each CPP program to support itself, right? So we make rules, John and Rheanna, that work in both directions at the same time, right? And we just need to think about those.
Carmen Lopez had a comment or two. Carmen?
Sorry, I don't even remember what I wrote, but I was typing away. And, as somebody that is trying to hire therapists all the time, it's so very difficult because, we are competing. The market is just way out of our range. And we have been having very much difficulty hiring therapists that can provide quality psychotherapy, not just like check-ins, but quality psychotherapy targeted for complex and high acuity cases. So that was, finally we have child psychiatrists, and then we have the barrier that we cannot grow our services more because of that. They're not out there. So it is really difficult to do that. And the other part is the reality that the the role of, you know, and as a child psychiatrist, I'm talking that way, is that when you treat a child, it's not just the patient, it's the whole bubble that surrounds them. And it can be really intense, and the burnout is very real. This mental health crisis, we've been living in it for years. So, you know, it's good that people are noticing, but we've been there.
Yeah, I agree with you. I agree with you. And I think that, you know, family work oftentimes is you know, it's time and, you know, energy intensive. And I think, but that also argues for focusing on family level interventions earlier on, before they get to that point. To the degree that they, you know, not that everything can be prevented, but I think some can.
We've a comment in the chat from Susan Klein. Susan, you want to get in here?
Sure. By history, we used to have an on-call system after hours and on the weekends where we had therapists. Not every therapist was eligible to do this, but they could do this, and they were incentivized. They were paid to do this, to take calls from our patients at night, 24/7 on the weekend and holidays, and it kept the ED visits down.
Thank you. Good point. Brandon mentioned a virtual peer support program. Brandon, you want to get in the discussion?
Yeah, happy to. Yeah, so I guess I was just surprised. So, you know, went to a talk that was talking about virtual peer support, and you know, having that as kind of a model where it could be an initial touch point and kind of like a step care kind of model. I guess what I was surprised by more than the talk was the colleagues in the audience that were like, well, what happens if someone has, you know, SI and a virtual peer support, or what if, you know, all the things that of course can happen kind of at any interaction with a patient or someone who's dealing with mental health. But in my head, I was thinking, you know, it's not like we have a current solution that's like solving, you know, the crisis that we're in. So it's more so a question of like, I wonder about resistance within our own colleagues or our own systems around these kind of decentralized interventions, and we saying, you know, oh, we can't do what we can do in the ER, but it's like, you know, we just have to mitigate those. It seems like we would just mitigate them best we can, but I'm not sure. Curious your thoughts.
Yeah, as to like, so you were wondering my thoughts on like, doing peer support programs.
Yeah, and also if you've seen resistance, because it feels like when we try to implement something like that, or even like a self-help or self-administered interventions for families, there is this question of like, well, what if you leave a donut hole because of it, or there's some risk that you've created?
Yeah. Yes.
I'm curious your thoughts on those concerns, I guess.
And do you need, like, is there risk that's created because you're opening up something that was previously not described?
Right.
I think that's the whole issue. Like, I think the tension that our colleagues feel around screening is like, do I screen for these things if I'm not going to be able to get anybody in for treatment, you know, for 9 months? So I think that that's real. I do like, I mean, I think a number of the projects that I've been involved in, there's sort of a dual purpose. So you know, the Mothers and Babies course is a group intervention, and it's not necessarily a peer-led intervention, but it's, I mean, it could be in the sense that it doesn't require a mental health professional for delivery, but there is an element of, you know, the more that we know about social support and loneliness and influence on things. So I'm a big fan, you know, we do it in part for that, and in part related to language and limited number of people who can deliver interventions and whatnot. But I think that there definitely is a role for it. But we do, you know, I agree with you that it is a challenge in terms of, okay, well, what if you, but then I guess the question is, what's the risk of not acting as well? But I agree.
Yeah, thank you, Ron. Oftentimes it's the difference between having a patient and family-centered approach versus an us-centered approach, which unfortunately is far too often the norm. I know that you and I have talked about our own experiences in doing studies with screening in primary care settings. And most of the pediatricians were open to doing screening, but about half of them would say, oh, you can screen in our practice, providing you tell us what's going on with our patients. And the other half of the room would say, no, 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 no. You could screen as long as we don't know anything about what's going on, because if we know, then we've
And we
got
have
to
to
do something, and we really feel pretty helpless.
Yeah.
Any other comments before we finish up? Any other questions or anything you'd want to mention, Rheanna, before we end here?
No, I mean, I welcome the opportunity, for those who are interested in thinking and talking about this, it's something I feel strongly about. So I'm happy to talk with anybody.
You not only feel strongly about it, but you've been an incredibly positive force for change in the region and also at the national level here. And I think that much of the discussion that we've heard just now just really highlights the tremendous barriers, many of them focusing around money and stigma, and I think they're related. Keep fighting the good fight. And thank you for an outstanding talk. It was a privilege to be here. Thanks everybody for joining.
Thank you, Rheanna. Bye.
Thank you. Bye.
Great round.